Good afternoon, everybody. Welcome to a beautiful day in the House Finance Subcommittee on Human Services. If we can just jump right in, and the clerk, if you can read the roll, please.
Vice Chair Slater.
Present.
Vice Chair Mazurkowski.
Present.
Representative Diaz. Representative Quatrucci. Representative Ruggiero. Representative Tabone. And you have a quorum.
Beautiful. Thank you very much. And again, we can just cruise right along. I know that the director of the Department of Health has a bunch of other engagements, so we're going to do that department in its entirety initially. So if Sharon can go ahead with the presentation, and then we'll call the director up and have questions, stuff like that. Go right ahead, Sharon.
Thank you, Chairman, members of the subcommittee. We'll do our usual overview of the department budget, in this case, Department of Health, one of the 4 agencies under the EOHHS umbrella. Programs in Department of Health are listed here. They are varied around community health and equity, lab services, and emergency preparedness, and a variety of responsibilities. A summary of the budgets before you by fund source. You can see the overwhelming majority of the funds come from sources other than general revenues, and the governor's budget actually is $364 million, with about $275 of that coming from federal funds. Quite a bit of this deals with the state's response to the COVID-19 emergency. So if you look at in the revised budget, traditional Department of Health programs account for only about $200 million of the total spending, and the COVID money is $440 million. For 2022, that starts to rebalance a little bit, but not completely. By category of expense, you can see that unlike some of the other departments we've been talking about, a very large portion of this budget is now dedicated to non-staffing expenses. Again, very much to do with the COVID-19 emergency. Already this year, since the governor submitted his budget on March 11th, you've had a number of hearings that affect items that are included in the Department of Health's budget. I've listed them here because we've included some of the information we've already provided to you, so I'm just going to go through that really by reference since you've already had those hearings, but it may come up and you may have additional questions for the department on those. But there are a number of programs you've already had hearings on these initiatives. The staffing recommendation for the Department of Health is just 4 positions above what was enacted. The department had requested 42 additional positions. There are currently 507.4 positions filled, so just a handful of vacancies. The enacted budget, the governor's recommendation for those 4 additional positions relate primarily to additional programs you've already had the hearings on, the Shellfish Dockside program, the public health data, opioid stewardship, and then some reductions because of changes in activity on the Vital Records satellite office related to Real ID. In terms of changes to the 2021 budget for the governor's 22 recommendation, you can see there's very large changes by gross dollar amount, most of which has to do with the COVID-19 funding. So we'll spend a little time talking about that. So overall, there's an $87 million reduction from general revenues. For COVID-19 and actually an add everywhere else for general revenues. And on the all funds, same, there's about a $20 million add that's not related to COVID-19. All the other adjustments are. This slide kind of shows you some of the federal legislation we've talked about in any number of hearings on the federal response to COVID-19 in terms of funding. These are the Cdc grants that came out of each one of those pieces of legislation. We've identified about $172 million dedicated to the Department of Health. You may also recall that most of the department's federal grants allow a percentage cost recovery charge for amounts that are received. We call that indirect cost recovery. So if someone gets a grant, they can apply an indirect rate to it as well as apply direct expenses to it. Currently, the Department of Health's indirect rate is about 19% of certain expenses. Some years that's a little lower, some years it's higher. These funds are taken from the grant and deposited into a restricted receipt account and then can be used to administer this or other programs, overhead charges in the department, very flexible funding. So this influx of federal stimulus funds does create an opportunity for some flexible resources for uses that may be a little more flexible than the grants themselves. So a recent history of indirect cost recovery funds flowing through the health department. They started fiscal 20 with a prior year balance of $2.6 million, got in $7.8 million in receipts, but only spent $7 million. And the enacted budget assumed there'd be a lower carry forward and lower receipts, but you can see now the revised budget is assuming both the carry forward that actually happened for fiscal 20 as well as quite a bit more in receipts. And so this money is mostly budgeted for expenditures in the next 2 years. So the governor's got $18.8 million in 2021 and $10 million in 2022. Some of them are not specified for use, so they're not really categorized yet how they'd be spent. The governor's budget includes provisions in Article 1 to require that there'd be an extra level of approval on how these funds do get spent. This is an unusual add of additional authority required to spend these funds, and it, kind of goes along with the unusual amount of money that's available for expenditure. In terms of other COVID-19 expenses, they are summarized here, what's in the governor's budget, $440 million for fiscal 21 flowing through the Department of Health's budget, with the greatest portion of that having to do with testing, but then of course all the other expenses, contact tracing, vaccine, surge. We'll talk about those in the slides that are coming up. Your 2021 budget accounted for some of this, but this budget revises it a little bit based on new information. And then the 2022 budget continues some of these expenses, expecting that there will be some activity past July 1. And you can see here that it assumes $162 million in all of these areas for fiscal 2022. On the testing side, the testing is done primarily through laboratory contracts. It also covers site supplies and equipment. As I mentioned, $277 million in fiscal 21. There's another $72 million assumed to be needed in fiscal 22. You had budgeted in your fiscal 21 enacted some general revenues, not knowing what would be available at the time you adopted the budget. This is one of those areas where general revenues were budgeted and not needed and were used to cover expenses that are needed to be covered in fiscal 22. Of the $277 million budgeted, quite a bit has not yet been spent. So it's under $100 million of it has been spent to date. And you'll see that as we go through. A lot of this is budgeted but not spent yet. There's the contact tracing. I've got the numbers here for you. The expectation is nearly $100 million in spending over the next 2 years. This is, most of the change is just adding funding for fiscal 2022. And again, this is a place where previously budgeted general revenues were swapped out for federal funds. Funding to support the vaccine campaign, that means personnel, storage, supplies, outreach. As you know, the vaccine itself is paid directly for by the federal government. The governor's budget has $60 million over the next 2 years. Again, most of that is added money for fiscal 2022. So far, $8.4 million spent through April 25th. So quite a bit not yet spent. You also are familiar with the surge hospital spending that's expected to be deconstructed this fiscal year. So the budget includes, with all of the expenses associated with that, $68 million. Not everything is eligible for FEMA. And so what was retained in the fiscal 21 budget on the governor's part was still $8.2 million of general revenues. If there was available CRF money, that could be swapped out as an available use, but not everything is available for FEMA. There's also funding for community mitigation, health equity zones, $9.8 million in 21 and $6.5 in fiscal 22. This is $12 million combined more than was assumed in fiscal 21. The health equity zones funding would primarily come from the CDC grants. There's also some general revenues, other federal sources, as well as 1.5 million of that indirect cost recovery we were talking about. The public health response itself, and that's communications, information technology, all of that expense. There's $29.7 million in the current year and $10 million more expected to be needed for fiscal 2022. These expenses are incurred in a variety of state agencies. The budget does include $27 million of federal funds for which no specific grant has been identified. And we've figured that that this was kind of a reserve in case needed, and that the administration assumed that there would be some future federal grants that would fund this. So these are not, this spending is not attached to any specific grant. So we'll need to have a grant identified for it in order for these funds to be able to be spent. Or if the expense is needed, other resources will have to be found. Rhode Island is receiving $63.9 million for combined, $63.7 million, about half for school testing, and about half of that for vaccine preparedness. So looking across all these items we just talked about, what's budgeted in blue and what's been spent on each one, you can see that the contact tracing and the vaccine campaigns are the one, and the surge ones are sort of the most off of what's budgeted and spent so far. Moving on to the sort of more traditional areas of the department's budget, we're just going to take you through each division. It's sometimes hard to remember all of the things the Department of Health does, so we'll sort of show you where all that money is and just do a quick synopsis of those programs and what the department's responsible for. You have the Central Management Office and all the administrative functions, as well as the Health Equity Institute. There is the Minority Health Program that works to eliminate racial and ethnic health disparities. The department, I mentioned the health equity zones. The department is requesting to use $500,000 for restricted receipts, additional restricted receipts to support health equity zones. That was what they had requested, and the governor added, as I mentioned, the $1.5 million in total, so that's a new $1 million for this expense. Opioid stewardship funds, you're familiar with this $5 million assessment against gross in-state opioid sales. These funds are then used for specific purposes throughout the state budget. You already had a hearing on March 30th about the restricted receipt accounts for this, so I'll just show you this current summary of uses proposed in the 21 and 22 budgets. And then on to the next program, Community Health and Equity, which has $5.3 million more in the governor's 22 budget than was included in the enacted. Most of that is federal funds. There is an additional $800,000 from general revenues. This division has a number of responsibilities, which translates into some familiar programs: women, infants, and children nutrition assistance, immunization, home visiting, cancer screening, tobacco control, and the WIC program, Women, Infants, and Children Nutrition Assistance. This is a $22 million program, provides supplemental food, nutrition, education, and information for eligible women and children under 5. There is also funding to support a staff of 13. The immunization program primarily is the purchase of vaccines. 90% of the funds for that goes to vaccines. There is some federal funds. Most of this is supported from restricted receipt assessment. The Assembly back in 2014 included an assessment to essentially all people who have health insurance through their health insurance provider to ensure there was sufficient funding for immunization. And There's seems to be about several $1,000,000 still in that balance. Those prior balances are used to set the assessment for the next year. So you can see by the childhood program and the adult program on this slide what the vaccine expenditures have been, small amount for operating costs, and then the balance across both programs ended at $17 million in 2020. There are also maternal, infant, and early childhood home visiting programs. You are likely familiar with these programs as we've talked about them with respect to some budget articles, but there's the First Connections, the Healthy Families America, Nurse Family Partnerships, and Parents as Teachers. The summarized here on this slide is from a legislative report provided by the Health Department about visits that were conducted in a prior year period. Those visits were done both virtually and in person. We presented some slides to you as part of Article 12, which is establishing some Medicaid coverage for some of these programs going forward, providing additional funding for each, one being the Parents as Teachers, and the other being the First Connections program. So this is here again for your reference. The next major program has to do with environmental health. The changes to fiscal 22 are actually, in this case, more on the general revenue side than the federal funds side. This program has the regulation and oversight of health services. It operates the license and inspection programs to ensure minimum standards are met with respect to food, water, and radiation sources. This also includes the blood lead poisoning prevention program, where there's staff that investigates complaints and inquiries about lead poisoning, arranges inspections, and makes referrals for case management. You may remember Governor Raimondo had proposed a few years ago that certain services be centralized from the Housing Resources Commission under the Department of Health. That proposal was not adopted into legislation by the Assembly. However, through a memorandum of agreement, the Department of Health has taken responsibility for enforcing certain lead mitigation and abatement activities with its agreement on with the Housing Resources Commission. The department's also responsible for licensing and regulating 7,500 food establishments. It conducts inspections and investigates food-related disease outbreaks and complaints. The department also analyzes water samples from shellfish growing areas. And several years ago, there was a major problem with and resulted in closures of shellfishing areas in Narragansett Bay, and some plans were developed for additional testing capabilities. You had a hearing on April 1st regarding a proposal related to this, and that was the Shellfish Dockside program, authorizing the director to establish a program through rules and regulations and a fee to ensure that the shellfish processors are meeting sanitary standards. That fee is dedicated, although it's deposited as general revenues, it would be dedicated for this expense. So in this governor's budget, you see the expenditure side of it, $400,000, 3 new positions, and some operating expenses to run the program. The drinking water program is also included in the Department of Health, and it regulates public water systems. The next major division is the health lab and medical examiners. And this program investigates and determines the manner and circumstance of death, certifies the cause of death in unnatural cases, sudden and unexpected deaths, which are otherwise unexplained. The governor includes funding from federal funds for the new medical examiners facility. You remember that this was also a part of the enacted budget, $2.5 million to purchase a facility in Cumberland that was completed November of 2020. Some of the personnel has begun to move. Phase 1 is adding additional capacity to address the surge. There's also some funding for vehicles and equipment. You provided some longer-term funding for Phase 2 with $5 million from RICAP funds in the Department of Administration's budget. So it doesn't appear in Department of Health's budget, but it is for this purpose, and Department of Administration is managing that. The Health Lab program provides lab services to state and municipal agencies, healthcare providers, and individuals. The Chapin Health Lab is the main facility that houses both the state medical examiner, the old office of the state medical examiner, and the health labs. I'm going to show you some things we've shown you in the last couple of hearings on this topic. This relates to a proposal to replace the health lab. There was a study back in 2014 that identified some possible new sites, how to handle either renovating or replacing this lab in its entirety. Any number of programs have been proposed since back as early as fiscal 2009, where the proposals have run the range of $65 million up to over $100 million, with a variety of things included, not included, and space covered. Back in July, Governor Raimondo proposed an amendment to her ballot initiatives and suggested adding $107 million for a new health lab and facilities. At the time, there was no identification of a location, and it did exclude the medical examiner. As we discussed, that new facility was underway at the time. And as you know, you didn't approve that. It did not go on the ballot. The department did request in its capital budget $112 million to go forward with this project. This was not recommended by the governor or included in his capital budget. As I mentioned, this project has been requested by the department in various forms for more than a decade. This month, the department issued a request for quotes for a new health lab building, looking at additional options to provide more proposals for consideration. Those appear to be due at the end of this month. There's also funding in the governor's capital budget to replace medical equipment, and that has been in the approved plan, and it just adds funding for the extra year of the 5-year plan. Moving on to other areas of the department's responsibilities, we get to the Customer Services Division, which has the professional licensing, vital records, health facilities regulation, and the medical marijuana program. Vital records, kind of self-explanatory. That is, a couple years ago, you authorized some funding for them to set up a satellite office at the DMV in Cranston to assist people who are trying to come into compliance with federal Real ID. As you know, that compliance has been delayed and most recently delayed again. So the traffic hasn't been what is expected, and so the budget sort of assumes that satellite is going to close and there'll be savings from that. Also, the department has the Center for Professional Boards and Licensing that licenses, certifies, and disciplines healthcare professionals. There's over 110 health professional licenses issued by the department, with a summary here. You just had a hearing on Article 15 that proposes to have Rhode Island join several interstate compacts affecting the 5 professions listed here and the 52,000 potential licensees. I didn't include all the information from that presentation. It's just here as a refresher. The next division of the department is the Policy, Information, and Communications that deals with health data analysis, public health information, and some more administrative functions. And again, this relates to another article you heard regarding requests for public health data fees, authorizing the director to charge fees for processing special data requests. It would allow the director to establish the fees through regulations, but also waive them at the director's discretion. Currently, there's no fee charged for that. The budget assumes that the state would generate about $400,000 in revenues, and then the budget appropriates about half of that back to the department to help fulfill the responsibilities. There's the next division is the Preparedness, Response, Infectious Disease, and Emergency Services Division, which again, self-explanatory. There's another $13 million above the enacted, mostly federal funds for this division. This includes emergency preparedness and infectious disease specific items listed here, and federal bioterrorism funds that helps hospitals and healthcare entities plan for, respond to, and recover from mass casualty events. The governor's recommended $6.2 million in fiscal 21 and $6.1 million in fiscal 22 for this in his budget. So that is a quick overview of the Department of Health's very complex budget, and I'm happy to try and answer any questions you might have.
It was a great and comprehensive overview. As always, any questions for Sharon? No questions for Sharon. And I do believe that we had a couple of representatives that jumped on the line. We have Representative Vella Wilkinson and Representative Quatrucci. If they could be marked as present, please. Thank you. All right, perfect.
Thank you, Chairman.
Next, we can move on to Director Dr. Alexander Scott.
Excellent. Can you hear me?
We can't hear you right now, though. Microphone on.
You can. Excellent. So I'm going to jump in. I want to make sure I heard your answer properly. And say good afternoon, Subcommittee Chairman.
It looks like we might be
as well as
having
members of the subcommittee.
some technical difficulties.
You cannot hear me?
You're not muted or anything? It doesn't look like you're muted.
We can hear her on the Zoom. Can you hear us? Can you hear her? Can you hear me now, Chairman?
Neil, you want to jump on while the doctor gets set?
Chairman, can you
I can hear
this
Neil.
This is
Yep.
Neil from the Rhode Island Department of Health. Can you hear me?
I can hear you. Yep.
But you cannot hear me?
Oh, and now I can hear you as well.
Okay.
So, doctor, go right ahead.
All right. So thank you very much, Chairman, and members of the subcommittee. Also, thank you to you and our colleagues for allowing us to go first on this important afternoon public hearing. We are honored to have the opportunity to discuss the Rhode Island Department of Health's revised budget for fiscal year 2021 and discuss our recommended budget for fiscal year 2022. I am so pleased and thankful to be joined by Neil Heitman, our legislative liaison, and Lori Zolano, the Rhode Island Department of Health's stellar chief financial officer. In addition, depending on the nature of your questions, we will have some of our other colleagues from the Department of Health on as well. And a huge thank you to the team who always does a tremendous job ensuring that we are prepared in reflecting the amazing work that the department does to serve the public's health. Before I speak to some of the specifics of our budget, I want to just take a moment, given the time frame, given where we are, and speak to the public health context that we are obviously in right now. For the past 14 months, Rhode Island has been responding to the largest, most complex pandemic in the history of our state, of our country, really of what's taken place worldwide. COVID-19 has tested all of us, including the Rhode Island Department of Health. And I can say without a doubt that I am enormously proud of how the public health professionals at the Rhode Island Department of Health have responded and continue to respond. They have worked night and day, countless hours, tirelessly for the last year and a half. The hours put in, the tears shed, and the sacrifices made have been immeasurable. And it's really critical to be able to acknowledge that and directly myself express appreciation to everyone involved for that. Rhode Island should be proud of the monumental efforts that have been made, and Rhode Island should be proud of the results, the outcomes that we have had. Starting with the work happening at our state health laboratories, we have been a national leader in COVID-19 testing. We do more testing than states that are 4 or 5 times our size, and we have consistently held that position as leading the nation for months. We've also been a national leader when it comes to schools and our COVID-19 response. We set up a first in the country education operations center as a state and are doing everything we can to get as many children doing in-person learning as possible, which we know is critical for their academic, social, and emotional health. We have some of the highest COVID-19 vaccination rates in the country, ranking top 10 across a number of markers, and our strategic approach to Rhode Island's COVID-19 vaccination campaign early on has resulted in greater decreases in cases, hospitalizations, and deaths than any other state in New England and than most other states throughout the entire country. And we have put equity front and center throughout our response. We've worked hard to build on our partnerships, such as the health equity zones, to get COVID-19 tools and resources into our communities that have been hardest hit, including our communities of color. We've been upfront and center in acknowledging when there's more work that needs to be done. But we continue to maintain that equity is a top priority for our COVID-19 response. I also want to take a moment here to acknowledge Governor McKee, who has been pushing us and supporting us in our work to address health equity throughout his time as governor. While partnering with our sister agencies and state government on all this COVID-19 work over the last year and a half, the Rhode Island Department of Health has continued to also perform the same critical public health functions that Rhode Islanders rely on every day to save lives. We promote healthy lifestyle changes. We work to ensure that the food and water you consume is healthy and safe so that there are no outbreaks from some foodborne illness. We regulate hundreds of healthcare facilities and tens of thousands of healthcare professionals throughout Rhode Island. We serve as a hub for critical public health data. We operate premier state health laboratories and services, and we run the state's only medical examiner's office, to name just a few of our dozens, if not hundreds, of core responsibilities. In the same way that equity was central to our work in COVID-19, equity has been and continues to be at the core of our work in all these other areas. Our 3 leading priorities have consistently been to address social, economic, and environmental determinants of health, to eliminate health disparities and promote health equity, and to ensure quality health services for all Rhode Islanders, including our most vulnerable populations. These were our priorities before COVID-19, and they remain our priorities now, with the additional focus on our ability to execute with excellence on accomplishing these. And if there's one takeaway that we have been able to ascertain and make clear for ourselves through COVID-19, it is that ability to execute. And we want to take that skill set and apply it broadly across all of the priorities that we have before us. In the same way that no person's health should depend on their zip code, your health should not be determined not only by your zip code, but also by your race, ethnicity, sexual orientation, gender identity, insurance status, level of education, or level of income. There's no doubt that this commitment has been put to the test for us throughout this pandemic. We've talked a lot about the disproportionate impact on communities hardest hit throughout Rhode Island, Central Falls, Pawtucket, parts of Providence. And these disparities are even more stark when you drill down to the race and ethnicity level. African American and Latino Rhode Islanders with COVID-19 who are 35 to 44 years of age are 3 times more likely to be hospitalized than Caucasian Rhode Islanders who are 75 to 84 years of age. Disparities such as these are the result of underlying community level factors, which has been our focus to address. We call these socioeconomic and environmental determinants of health, where someone lives, where they work, where they learn, where they worship, where they play. As a society, we invest a lot in healthcare. While healthcare is very important, what COVID-19 has made crystal clear yet again is that our health outcomes are largely determined by factors in our communities, where we live, what those living conditions are. 80% of health outcomes are determined by the socioeconomic and environmental determinants of health. 80%. An example of socioeconomic or environmental determinant of health is employment. When we had elevated rates of community transmission of coronavirus, you were at greater risk if your job required you to be present at work every day as opposed to a job that allowed you to work remotely. I'm talking about certified nurse assistants, grocery store workers, people who work in public safety and sanitation, and all the people who we depend on every single day. Addressing these community level factors is not just the right thing to do, it's also the most effective way to prevent transmission of diseases such as COVID-19 and help get Rhode Island through this pandemic and any other syndemic or epidemic concerns that we have. One of the ways we are ensuring that these community level factors remain a focus is through the establishment of the dedicated COVID-19 unit. The COVID-19 unit is responsible for providing and reinforcing public health guidance, also tracking and minimizing the spread of disease, and as I've shared, also promoting equity throughout the response. All of this is happening with a renewed focus at the Rhode Island Department of Health on execution. Governor McKee's 2022 budget includes $161.7 million related to COVID-19 pandemic response and recovery. This funding would support the work happening in the COVID unit at the Rhode Island Department of Health. You've seen the numbers outlined already, but I'll spend a moment giving you a little more background on these categories. Testing is still going to be key for us as we continue this pandemic response. Testing is how we get ahead of outbreaks, clusters of cases, identifying them, and being able to stop outbreaks before they happen. This is particularly important with more contagious variants of COVID-19 circulating now in Rhode Island and for those that may arise going forward. Also, we're going to need to keep supporting our vaccination campaign because we're getting closer to the last leg of the race, which is usually the hardest leg as well. To get us to herd immunity, we need to get into every corner of the state and get them vaccinated and do everything we can in terms of access to vaccines and education about getting vaccinated. I often say testing, treatment, and vaccination is what's going to see us through to the end of the pandemic successfully. Contact tracing is also critical. Effective contact tracing is what gives us the confidence we need to reopen, knowing that we can get people into quarantine quickly after an exposure and stop further spread unknowingly to other individuals. This will allow us to limit the negative impacts on schools, on workplaces, and on the community as a whole. That surge row in the table that Sharon showed is all about our ability to scale up our response as needed, should we see any kind of resurgence related to the variants or otherwise. And finally, community mitigation is the term we use to describe our work to put science-based, data-driven public health guidance in place that is key to preventing transmission of COVID-19. The most visible public health crisis we were responding to before the COVID-19 pandemic was the issue of substance use disorder. That crisis has not gone away. After seeing a decrease by 8.3% from 2016 to 2019, unfortunately, accidental drug overdose deaths in Rhode Island increased by 25% from 2019 to 2020. Fentanyl continues to be a factor in the majority of overdoses, often in the form of counterfeit pills. 3 out of 4 overdoses in 2020 involved fentanyl. Governor McKee's Overdose Prevention and Intervention Task Force has a range of plans in place to address these trends head on. Some of what's in place is some of this work is supported by the Opioid Stewardship Fund, which is money from an assessment on opioid products sold or distributed in Rhode Island. To make sure we are most efficiently and effectively utilizing this opioid stewardship funding, the governor is recommending $1.9 million to cover various costs, including a new FTE to manage the finances for the Opioid Stewardship Fund and staffing costs for FTE positions working on the opioid response. Many of the traditional public health tools that we use to respond to the opioid crisis, such as treatment, prevention, education, recovery, and surveillance, need to similarly be put in place when it comes to adult use cannabis. The adult use cannabis budget, Article 11, would invest $1.1 million in EOHHS's budget for health equity zones to expand community-driven health initiatives and infrastructure supported by the Rhode Island Department of Health in these same areas: treatment, prevention, education, recovery, and surveillance. $366,785 is specifically dedicated to RIDOH for public health prevention and surveillance activities targeting vulnerable populations, including young adults, pregnant women, and people with disabilities. Our health equity zones are a ready-made infrastructure at the community level for this kind of critical public health partnership. Health equity zones are 11 collaboratives throughout the state where we are providing seed funding to help people and organizations use collective action to build stronger and healthier communities that will be transformed and sustained for the long term. Over the last few years, the Rhode Island Department of Health has worked with each health equity zone to develop each collaborative's infrastructure by bringing together residents and each community's strengths, whether it be within law enforcement, education, elected officials, municipality leadership, businesses, planning, and so many other areas. Our health equity zones are about shifting investments from traditional healthcare settings and placing those investments where they are most needed, focusing on those community level factors that I referenced earlier, where 80% of health happens. When we do this, we not only get better health outcomes for individuals, but we get a stronger, more vibrant Rhode Island because we're able to cut costs and we have healthier communities who can contribute to a thriving economy most effectively. A separate budget request for fiscal year 2022 that, just like health equity zones, is about shifting investments to the community level is family home visiting. Family home visiting is a home-based service provided during pregnancy and early childhood. The program ensures that pregnant women and families receive the necessary resources and skills to raise children who are physically, socially, and emotionally healthy and ready to learn. While federal funding has helped the state establish a strong foundation for family home visiting, That funding has declined considerably as anticipated. And we are requesting that state funds, because this program meets critical needs for Rhode Island families and has proven itself to be effective, would replace what's needed to continue this program for going forward. Because we understand at the end of the day that this program saves Rhode Island money. Rhode Island's 3 evidence-based family home visiting programs are Nurse Family Partnership, Healthy Families America, and Parents as Teachers. These 3 programs serve almost 1,800 families per year. Research suggests that these programs can save more than $74,000 per family served. That's a return of $8 for every $1 we invest. In January 2019, Rhode Island received approval from CMS under the Rhode Island Comprehensive Demonstration Waiver that would allow for adequate use and expansion of this funding. Without this funding, we will have to reduce the number of families we serve. The governor is recommending $1.4 million as match to current state funding of $0.6 million for this program to be effective. A separate family home visiting program is First Connections. We are requesting support to expand First Connections to better serve women in the prenatal period. The primary referrals for this program come from the developmental screening performed by Rhode Island's birthing hospitals and referrals from DCYF. The program serves about 3,000 families and 135 pregnant women per year. However, First Connections is able to respond to about only 5% of the prenatal referrals received. To better respond to that demand, Governor McKee is recommending $0.2 million with $0.1 million coming from general revenues. This family home visiting investment is consistent with the governor's larger vision of a post-pandemic Rhode Island recovery process. We have already started having these critical conversations about the investments we need to make in our communities to get every Rhode Islander in every zip code an equal opportunity to thrive in the best communities they have. The pandemic has without a doubt brought to light just how critical public health is, and it has brought to light just how important it is that we appropriately fund programs that address the community level determinants of health. This is how we achieve our long-term goals of a healthier, more prosperous, more equitable Rhode Island. Before wrapping up, there's one critical physical infrastructure issue that I want to bring to your attention, which is the situation at our state health laboratories. Our state health laboratories provide vital services that are needed to protect the public across a variety of sectors. During the pandemic, the lab played an even more prominent role. The state health laboratories has been the heart and soul of the nation leading testing operation that we are running. However, as we presented to the committee last year when a bond was being considered to fund the construction of a new building, the reality is that the current state health laboratory facility is woefully inadequate. The aging facility continues to provide inadequate space, and there are serious safety issues with the utility systems, air distribution and ventilation, temperature control and air quality, and the physical structure of the building. We are very encouraged by the inclusion of capital projects funds in the recently passed American Rescue Plan and look forward to working with the committee once we receive clarity from Treasury, who we also engaged with this morning, on what amount of funding will be eligible to be used to help construct new health laboratories from the federal government. I am grateful to our state health laboratory Rhode Island Department of Health staff who have continued to come in day after day, including at the very beginning of the pandemic when everything was shut down and people had to stay home, but have done it with a smile on their face, have done it with commitment and passion, and have done it in spite of the environmental setup at the current state health laboratories. The one way to be able to thank public health and Rhode Islanders who have served the public is for the public to join behind us in making clear that a state-of-the-art state health laboratory is exactly what Rhode Island needs to prepare us for the future best. We've demonstrated that we have the skill set and the ability to execute. We now need the facility to be able to support us in doing that. I'll wrap up by saying that I consider myself beyond fortunate to oversee a health department in a state where the top priorities of all of our leaders, including yourselves, are the health, safety, and security of the people we all serve in every single zip code. I'm thankful to Governor McKee as one of those leaders and to you, the committed members of this General Assembly who fight for Rhode Islanders every day. I want to thank you for your support, your guidance, your commitment, and especially that during this very challenging time. I look forward to all of the good that we will accomplish together in the year to come. And thank you for this opportunity.
And thank you for your testimony, Doctor. Any questions for the doctor? Representative Diaz says she has many, so be prepared. And then Representative Tabone.
Thank you, Mr. Chairman, and don't scare my good Department of Health. Dr. Scott Alexander, we are beyond thankful for having you leading the health crisis that we have in the state. We thank you for your leadership and your capacity to keep us above of the water. Please, I have a few questions, and hopefully Sharon will help me to interpret my questions. And the first one is, as we're facing this difficult time, I remember in the previous budget that we were talking about having limited staff to inspect restaurants and facilities that require the Department of Health be working on to keeping those businesses complying with policies and regulations for the Department of Health. The question to you from that part is, the Department of Health has been increased the numbers of inspectors that go out and be sure that businesses are following regulations. Are you there?
Yeah.
Thank you.
Thank you for that question. Similar to our charge with being able to care for restaurants as well as the hundreds of healthcare facilities that we oversee. Being as creative and innovative as we can to ensure that safety and quality comes from those facilities is our top priority. And we will continue to welcome the support from the General Assembly to have the resources needed to continue that function. We've been able to maintain it. I'm so grateful to our Food Protection Center, who has stepped up to the plate to ensure the services we had previously were in place, and then do that even more so during the pandemic response, the same way we have in our nursing homes and assisted living facilities. And while we have been able to respond to that, we continue to welcome the resources needed to sustain that for the long term so that we can continue to execute with the excellence that we strive for.
Following this question, Director, also, are you including bilingual staff to serve into the community because we have so many business owners that English is the second language?
It is always a focus for us. Certainly, as we've been able to build out our COVID response unit, which we've had to do extremely quickly in order to respond to the very dynamic elements of this pandemic. We have been proud of the ability to diversify our staff to do that and to help provide the support that's needed. So we continue to focus on building on that success as we expand and integrate into our overall RIDOH approach so that inspectors and other public health practitioners that are engaged in the community continue to be equipped with either their own or the tools to support them in communicating effectively with members of the community that are multilingual.
Thank you. Could you please provide me or provide us the update of the state medical examiner? I remember we have a long conversation in previous years, and we are following very closely the process of moving the facility to Cumberland. I would like to hear from you if we sold the the property here in Providence, it was sold or not, and what phase we are in the process to move into Cumberland.
Thank you. We would welcome being able to sell the current property, but that would mean we'd need a new state health laboratory so that we can get the several million from the current property because both were combined on the same property. And so our state health laboratory is still there. We are eager to get the process for a new building for a state health laboratory over the finish line so that we can then sell the property that housed the medical examiners and otherwise. We have completed the process of initiating movement into the Cumberland office and fulfilling the sale that has been needed, leveraging the funds that we have. So that process is moving forward. I'm pleased with the administrative leadership that we have with our medical examiners, and it's been a great setup for bringing in extremely strong chief medical examiner leadership as well, which we are anticipating. So Cumberland is moving along well, and our focus is on the state health laboratories and generating all of the support to galvanize getting us over the finish line with having a state-of-the-art building for our forensic, environmental, and biological sciences laboratories.
Thank you. I got two more. So I understood the process of moving the examiner. I'm sorry. Sorry. There's so many questions I have for you. I understood the medical examiner process. Now, I have a question for you about the health laboratory program, the process to find a location for it. According to the presentation today, we are planning to allocate $112 million GO bonds on 2022, which I assuming is for the coming November election 2022. If that is the case, and it's up to the voters to vote for $112 million for the health laboratory building, why we have to wait to 226 to execute that? In terms to approve the plan and adding all the funding on FY 2026. Why is 4 years between? I know the process takes time. I understand that would be, but to me, it's waiting for a next election again. So I got some problems there.
Yeah, and I'll get started and we'll welcome Neil or Lori Z to add some more detail. What you're describing, Representative, is the description from the previous budget that was noted when we were talking about a bond approach previously. We have transitioned to being able to move forward now in taking advantage of federal funding that is made available and will hopefully target state health laboratories, and have taken the steps, as you can see with the activity we are doing, to be shovel ready for funding as soon as it's available. We know exactly how much. It's significantly less than a 112 million. It's well under 100 million. We have are obtaining confirmation on the proposals for sites. We are certain of sites that will work well and want to make sure we haven't missed anything or dotting our I's and crossing our T's. And we will be ready to go, and just want the support from you all in the General Assembly so that we can get this going as soon as possible. In the meanwhile, money is getting sucked out of the current facility because of all of the work that's needed. It will be cost effective for us to be able to move quickly on getting a state health laboratory, state-of-the-art building going now, save money that way, and really prepare Rhode Island for whatever is to come in future pandemics, knowing what we can accomplish with the right support.
Thank you so much. And my last question is, look into the customer services that you provide, which include vital records, include contact with the residents of Rhode Island, when people are requesting birth certificate, marriage, and so many other documents that Rhode Islanders sometimes have to go to the department. Are you, based on the recent census data, you see the bilingual or minority community is growing. Are you contemplating, or you have enough staff to serving to bilingual residents when they go to the department, or are you planning to increase those numbers? And that is my last question. Thank you so much.
These are great questions. You know, we continue to focus on our ability to serve all Rhode Islanders. We always appreciate and are seeking out diverse staff that are able to help us respond and help make sure that Rhode Islanders are seeing reflections of themselves when they're coming into our offices. And we're also looking for updates to diversify, being able to respond, continuing to ensure that we have the online access that we've worked hard over years to be able to move towards, make sure multiple languages are available as well, and even consider and explore moving locations so that we are in closer proximity to other places where such services are needed. So we are constantly assessing ways to be responsive to the communities we're serving.
Thank you, Director, and Mr. Chairman, thank you so much.
Thank you for all those wonderful questions. Next up, we have Rep. Tabone with some more great questions. Go right ahead.
Thank you, Chair. Dr. Scott, how are you?
Doing well, thank you.
How's the baby?
He's doing well as well, 22
Great.
months.
Awesome.
Thank you.
Dr. Scott, I'm going to focus primarily on the COVID aspect of it. How many, do you have a rough idea of how many tests we did last year or throughout the last 12, 13 months since the pandemic?
I can get those numbers for you. I know at this point we are averaging about 120,000 tests per week. So we have, far surpassed what any other state has done, and surpassed, or are looking to surpass the 1 million mark for our own state. I'll let anyone else on the team add in if they have the exact number.
Okay. Also, so now in regards to inventory or of tests that we currently maintain, do you or anyone on the team have that number? And what do we have in stock
We have the ability to ensure that we are responsive. We've done over, and I have that number now, 4 million tests, and have been extremely responsive to what we've needed to learn to build out such a robust system. It does not involve stockpiling the tests in any way, because we constantly need to use them and get them going with the number of tests per day that we have compiled. What it does involve is contracting services with laboratories that are in states, so we are not dependent on other states, and the ability to generate what's needed and ensure that they are directly connected to the manufacturers that are going to provide the supplies that we need, and can avoid situations where we may have run short early on in the pandemic. We now have a solid, steady flow in terms of our ability to produce the tests that we need to do.
Okay, and how many different types of tests have we looked into or studied eventually land on the ones where are we using just one type in regards to like the PCR, which is the more in-depth test, or are we using several different ones?
Definitely several different ones. Our number one focus has been to ensure that we are diversified in how we can respond. We have a number of PCR tests. We're actually expanding to pooled testing via PCR. We have a large variety of rapid tests that are available. So diversification and ensuring that we have multiple approaches are the key to the ample supply that we have and the hundreds and thousands and millions of tests that we've been able to conduct.
Okay, and the reason I ask is because I'm not going to pretend to be an expert on this by any means, but you know, we happen to read about different things, especially in these positions, and there's been growing concern as to some of the testing creating hemorrhages and stuff for the individuals who have to do it frequently and have to do the brain pinch, you know, and so that's a concern that I have. And then that leads me to the type of testing we're either doing at schools or looking to do long term. What are we doing with the youth? What kind of testing are we doing? The accuracy of those tests, and how fast we're getting the results. So I can't imagine that all the youth are getting what I call the brain pinch, because I mean the pain, and I think a lot of them would stop going to school just thinking of having to get that so frequently. What are we using?
Well, I'm thrilled that you're asking, so I'm able to fully clarify that. There's no.
We lost you. You're muted.
Is occurring. These
Okay.
are. Can you still hear me? I was getting a call at the same time. There is
Now
no
we
brain pinching, bleeding, any of that that's going on with these multiple tests. These are very simple nasal swabs done at the edge of the nose. They are seamless. We are able to even teach older kids how to do it themselves. I can certainly reassure you in any concern along those lines. These are accurate and effective tests. They have done a phenomenal job in helping to ensure that we stay in front of any wide-scale outbreaks we've seen in schools. There has been no long-term transmission of multiple cases within a school setting that has occurred, and the tests have been critical to helping us ensure that we have safe environments in school settings, in work settings, and across Rhode Island. The fact that we have led the nation in testing is why we are doing so well along with our vaccination campaign. So I hope that really gives you the confidence needed that you no longer have to use that terminology and can know that this is a safe and appropriate test for our kids with a turnaround time that is extremely rapid. Particularly with the PCRs, 97% we're getting turnaround times within 24 hours.
So just for the record and for the to clarify for the people watching, and not to go too in depth, but if you could just explain, because the difference between both tests, the one that really goes deep into the tissue, and then the one that just the nasal swab. Can you just give us a synopsis of what that is? Just again, because this is where a lot of people get confused, and I'm trying to understand as to a child coming in, getting tested. I understand one gives you the accuracy within a day, the PCR, and then the other one, it's if you're symptomatic or if you're carrying it, right? But it's if you're
We'll be happy to have someone come by and show you how simple the swab is. I definitely had shown it on one of the press conferences. All of the tests, regardless of the PCR or rapids, are simple and easy. They are able to be ordered on the same day. Kids can do it. It's a self swab right at the front of the nose. There is no discomfort. That was, earlier on, there were some deeper nasal swab tests. We've all transitioned. So I really want to help make sure the public hears. These are simple, easy tests. It's why we are leading the nation in testing, because people have recognized how easy this can be done without the concern of any discomfort or pain. It's a quick tickle. We get the swab. The results are quick. They're accurate. They're helpful. It makes a difference. That's the message we want to continue to encourage.
Great. Well, Director, again, always great to see you. Thank you so much for all the work you're doing. And that's it for me. Thank you, Chair.
Thank you for that. Great questions. And looks like in the online universe, we have Representative Quatrucci has a couple of questions or a question. Go right ahead, my friend.
Yep. Thank you, Chairman. Can you hear me okay?
Yep.
Okay. Hi, Director. So many of the important decisions that we have to make are going to be based on such important data. And to kind of follow up on Rep. Tabone's questioning with PCR testing, and as he stated, we get a lot of information from our constituents, all kinds of writings and literature and videos. My questions about the so-called thresholds with PCR testing, being that it's such a sensitive test, and that it can actually misdiagnose from what I read and what I've learned. So what types of thresholds? Maybe you can explain to us what they are, the thresholds for the PCR tests, and where they lie. Because from what I understand, as they move, the data is dramatically moved also.
So for PCR tests, the thresholds that you are asking about is what is causing a test to be positive versus what's causing a test to be negative. The tests are highly accurate and very sensitive. So they work very well, particularly the PCR test. There are very rare situations where you can have a false positive. It actually does not occur commonly, and especially because transmission has been high in Rhode Island, the tests actually work best. As I have said since the beginning, when someone has symptoms, and particularly when you're in an environment where the transmission is high, a positive result is extremely effective. There isn't any real movement of the cutoffs or thresholds for tests. Each test might have their slight nuance, but there are specific references for what's a positive and what's a negative. And so that cutoff is what we use consistently. And really just for the public, it's just about understanding these tests are valuable, they work. work best when someone has symptoms. They're extremely helpful when you don't have symptoms still, because they're able to help us get in front of what we need to identify and help prevent spread, whether invisible spread or otherwise, because we can respond to it, as I said earlier, talk about contact tracing.
Okay. Do we use threshold graphs, such as I've seen? Do you use those in the Department of Health?
So our state health laboratory has a very comprehensive system that's used to determine when a test is positive versus when it's negative, and we'll use that data to help understand what we are looking for with the test. And they work very closely with the reference laboratories that we have contractual engagements with to help expand and provide the testing throughout the state. So thresholds are set by the manufacturer under FDA authorization, and we're able to track that and monitor how we're doing. There are countless measures in place to assess and ensure the validity of those tests that our laboratory is excellent at being able to maintain, as demonstrated by the multiple certifications from our federal partners that we pass with flying colors every time we go through those assessments. But it's definitely a complex system of oversight that our laboratory has, in addition to the laboratories that we work with across the state.
Thank you. And you mentioned it actually being a rarity to have false positives. Do we have any data on exactly how rare?
Yeah, we can provide that for you separately. It's single-digit percentages for when it occurs, and it's usually based on the context and as a clinical decision ultimately. But by and large, the the response that we get is for a reason and is accurate and is what we should respond to, so that we can help catch people who have the virus in their system. That's what the tests are critical for. It isn't going to tell you whether you are on the front end of infection or on the back end of infection, but does tell you whether or not there's a risk of you spreading the virus. And that's what's key for us in stopping spread, particularly to someone who's more vulnerable, whether they're immunocompromised or older or pregnant or young. Those are the individuals that we really want to help protect against, invisibly being exposed to the virus. And that's where the testing is critical for helping us in stopping that from occurring.
Okay, thank you.
All right, thank you very much. Any other questions of the doctor? All right, I just have one question, just because we were talking about the lab so extensively. The price reduction, or the estimated price reduction to be under $100 million, is that because we're now forsaking the private partnership?
Yes, it's a way for us to really go forward focusing on the RIDOH State Health Laboratory component initially, and knowing that that can serve as a catalyzer for bringing on more private capital support. It's what we need in our knowledge district. It's what we have assessed will be extremely valuable, and it allows us to really conserve how much funding is taken from the state in general revenue, and allows it to serve as an attraction for that private funding to be able to cover anything beyond that, knowing that partners are looking for the type of resources that a state health laboratory brings. We're the only biosafety level lab 3 in the state. We would have state-of-the-art services that would allow for additional partnerships, and conserving or consolidating to really focus on the state health laboratories and have the funding come through state or federal funding that way allows for us to attract additional capital funding to bring on those partners in association, but coming from the private funding market to do so.
All right, great. Thank you very much. But there is a potential in the future. It's going to come up in the back end. There's going to be a private partnership. It's still on the horizon.
Yeah, we would love that, but particularly with the private funding that supports it, and we know that's what private entities are looking for. They're looking for that stable, strong resource, such as a state health laboratory, to align with academic partners are, our healthcare system partners are. Other private capital funders would absolutely be looking for that. And so really establishing the state health laboratory as that foundation will serve as the attraction, but then have it be covered by the private funding to bring in more talent as well as resources to the state.
Great. Thank you very much. Any other questions of the doctor? Anybody online? Nope. So it looks like you're clear to go. Thank you for all the work you do. Be safe.
You as well. Thank you. And thank you to the whole team who's great in making sure that we were strong and ready for this. Appreciate you. And thank you to the General Assembly and Committee. Have a good evening.
You got it. Bye-bye. Okay, next up we can go back into, we actually have somebody online. I believe it's Corey Chandler. Corey, you are on live with House Finance. If you could just introduce yourself and talk to us for a couple of minutes about the positions you're holding. Go right ahead.
Absolutely. Thank you so much. Good evening, Chairman and members of the committee. My name is Corey Chandler. I'm the Government Relations Director here in Rhode Island for the American Cancer Society Cancer Action Network. I wanted to first thank you for the opportunity to testify on the proposed budget for the Rhode Island Department of Health. My testimony relates to the proposal for the funding for the Rhode Island Tobacco Control Program. I've submitted extensive written testimony in collaboration with the American Heart Association, American Lung Association, and Campaign for Tobacco-Free Kids, so I'll keep my verbal remarks brief. Essentially, we're concerned that the budget proposes only maintaining state funding for the program at just over $396,000. The CDC actually recommends that we fund this program at $12.8 million. At its high point back in 2002, we were funding the program at $3.2 million. Since then, we've witnessed a steep and a very concerning decline in funding. But I want to highlight the fact that tobacco use remains the largest preventable cause of disease and premature death in the United States, and that remains the case in Rhode Island as well. Smoking is actually responsible for over 28% of cancer deaths here in Rhode Island. While we have continued to decrease our state's investment in this program, we've also seen a concerning increase in youth use of tobacco products. Currently, over 33% of high school students reported using tobacco products, with over 30% reporting that they use an e-cigarette, and that number is compared to 20% back in 2017. So if we don't take immediate steps to reduce the toll of tobacco on our state, 16,000 youth that are now alive in Rhode Island will lose their lives prematurely from tobacco use. Our adult smoking rate is also higher than both of our border states, Connecticut and Massachusetts. I did, with my testimony, include projections as well from the Campaign for Tobacco-Free Kids, and those projections state that increasing annual tobacco control funding to our 2002 historic high of $3.2 million would mean that 500 fewer Rhode Island children would become adults who smoke, and sustaining this level would decrease future health care expenditures by $10.5 million. We've been consistent proponents regarding the importance of this funding, as I'm sure many of you are aware, it's the case because we know what works to reduce tobacco use. Studies have actually shown that funding tobacco control programs have a direct impact on rates of tobacco use. So as our state continues to recover from COVID-19, we must continue to build strong public health infrastructure, and that includes the tobacco control program. We believe that with the relief that our state has received from the American Rescue Plan Act, this year is an opportune time to restore Rhode Island's commitment to protecting our youth from the dangers of tobacco use and assisting adults in quitting. And I'd be happy to take any questions that you have.
Thank you, Corey. Any questions for Corey? Nope, and we have your written testimony right in front of us. So thank you very much for your verbal testimony as well.
Thank you so much. Have a good night.
All right, and then next up we can go back to Sharon and going through the slide presentation for the Office of the Child Advocate and DCYF. Sharon, whenever you're ready.
Sure, and we'll again quickly take you through summaries of the budgets before you for these two agencies. Again, DCYF is another one of the four entities under the umbrella of the Executive Office of Health and Human Services. And we didn't have this in the last slide, but you can see where they fit in the scheme of things and the $3.4 billion total budget for these entities. And just as a reminder, the extension of the public health emergencies meant more money in all the agencies that get Medicaid match, and that includes DCYF in both 2021 and 2022, some temporary enhanced Medicaid match. DCYF separates itself into several budget areas. These are listed here, largest of which is child welfare, and then smaller programs for behavioral health, juvenile corrections, and then the administrative component, as well as a separate line for the higher ed grants. The overwhelming majority of the spending is on the child welfare program itself, and more than half the funding does come from state general revenues. All of that is summarized in these tables before you, and you can see that the 2021 budget is not that different from the one that was enacted back in December, but we'll take you through just a couple of changes to note. There is a total of $1.2 million more from all sources. Some of that is just a shift of federal funds for state general revenue funds, an opportunity made available by additional CRF funds. There's an adjustment for some statewide benefits, and then there's additional funding to meet a new requirement to keep children in care a little bit longer because of COVID. Overall funding by source for fiscal 22, about 30% federal funds, most of the rest coming from general revenues, and most of these funds are paid out for services, which falls into that assistance, grants, and benefits category. About a third of the budget is spent on staff. We've updated for you over the past couple of years just some key points in the history of the department, which has gone through a number of changes. Back in March of 2017, there was a new director confirmed. Less than a year later, the state entered into a settlement for the children's rights lawsuit. And then in September 2019, that director did resign her post, and there was a contract brought in to look at some potential savings and other organizational issues. In August of 2019, there was an announcement about hiring additional frontline positions. Less than a year later, of course, the pandemic began. Back in December, it was identified that the department was again going to begin hiring frontline positions as the pandemic started to wane. And we would just remind you that at this point, you are still the department is still being led by an acting director. The same one since the director resigned back in September. So that is just kind of a recent history of events. In terms of the current year budget, as I mentioned, it's not that different. You do have different measurements that we've taken over time. What was finally budgeted for the fiscal 2020, and then what was spent. You can see that there was actually some underspending there. The department requested in its initial budget back in October, before you had even finished adopting fiscal 21, considerably more money, but reported both in the quarterly reports for quarter one and quarter two the need for less than that. And basically, the governor's revised budget is on par with the enacted budget and what the department is projecting a need for. And the salaries and benefits, which again is a significant component, not the overwhelming majority, but are listed here for your information, because there's been quite a bit of discussion around staffing and how much money the department has to fill vacant positions. The governor's budget basically assumes all but less than 10 of the department's authorized positions will be filled throughout fiscal 2022. There are currently there are currently 589 positions filled, and that means the governor's budget funds 29 positions more than are filled today. The staffing complement 617.5 FTEs for fiscal 21 enacted. The governor retains that in the revised budget. The request was for more positions. The governor's budget adds a net 10. And you can see that on this slide that there's a shifting of positions among the programs. There is a net add, and there were vacancies that are being eliminated, mostly in the Juvenile Corrections program, and those vacancies are repurposed for more frontline staff, as well as there's an overt addition of people for more frontline staff. The history of staffing authorization versus filled positions. We've tried to give you this for the past few years because there's been a high level of vacancies at the department, and over time you've ratcheted down the cap on the department's staffing based on these vacancies. There have also been a couple of instances where positions have actually just been transferred to another department. They're not eliminated, or there's no net reduction for the department itself. This occurred as part of the fiscal 2021 budget, where 4 legal positions were simply moved from one place to another. And you can see the 589 positions that are currently filled through mid-April. As I mentioned, the governor's budget is just a little bit more than was enacted for 21. This accounts for some federal funds needed to fund staffing and isolation housing for youth and families, and like I said, some additional opportunity to save general revenues by shifting costs to the CRF funds. For 2022, staffing costs are nearly $80 million. That's $6 million more than enacted. Most of that is from general revenues that both restores the one-time federal funds, but also includes funding for new frontline staff, some paralegal positions, and increased staff in the licensing unit for recruiting, training, and sustaining foster families. As we talk a little bit about the placements, you'll see how this spend factors into the budget request. Just by way of overview, the 3 divisions providing placement and services each deal with different populations, as shown on this slide here. Primarily, your child welfare and children's behavioral health are dealing with children under DCYF direct supervision and families in need of services. The juvenile corrections component deals with youth adjudicated through the family court. Each gets funding from a mix of state and federal sources. In terms of the types of placements available, there are different kinds of foster care, kinship, non-kinship, private, and specialized. You have residential group care. You have child care provided to foster care parents and eligible families, and there's independent living programs. There's also services provided through assessment and stabilization centers, and then home and community-based care. And we've, again, provided you just a short description of these programs for your reference as we talk about some of the funding. You may recall that as 2020 was coming to a close, there had been a growth in family-based foster care placement, and that did produce some savings because group placements had decreased. At the time, the department indicated that this was likely a temporary trend, pandemic related, and that certain foster families had agreed to do some temporary housing of youth, and then it was likely that this would not be retained. And based on the quarterly census, that's what we're seeing. If you look at this table, you can see that although the end of the fiscal 2020 quarter had 1,601 children in foster care, through April 1st, we're now at 1,460. And so you can see that the other placements also increase as that number goes down. So the foster care are the home-based placements, congregate care, the residential, that's group homes, residential treatment facilities, semi-independent living, And here the costs of these programs are summarized for you. $58 million in the enacted budget, 63 in the governor's proposal. The department plans to open 2 female psychiatric residential facilities, and the budget provides $3.5 million for that for fiscal 2022. This assumes 2 12-bed facilities for a total of 24 beds to be opened October 1, 2021. As far as we know, those have not yet been identified. Those who would be housed there are currently largely housed at out-of-state facilities, and there's not current capacity in the state to house them. There are also subsidies for adoption assistance and for both relative and non-relative guardianships. This is the way the department helps to seek to maximize permanency. Funding for these programs is also listed on this slide for your reference. You can see that these are slight changes in the governor's budget from the prior year. For home and community-based services, these are counseling, education, family support services, family-centered treatment. The governor's budget is based on prior year utilization and just about level funded with 21 from an all funds perspective. There was money in the 2021 budget from coronavirus relief funds, and that supported special stipends for foster care, isolation and intake placements, as well as executive orders regarding continuance of service for those in the voluntary extension of care program. The governor's budget also has a number of initiatives around placements that we've summarized here and noted where there's FTEs involved and what the savings or cost assumed to be part of that here. And I'm just going to quickly run through those as well. There's savings assumed of $2.8 million from those positions I mentioned hiring, and that's to help foster care recruitment and as youth shift from the more expensive congregate care placements back to foster care, the budget assumes these savings will be achieved. There's also an assumption that the state will not immediately be in compliance with some new federal Title IV-E programs, and so the budget does provide about $400,000 from general revenues to make sure that any lost federal funds are accounted for. There's also a new staff person to ensure that people are placed in the right setting, and the governor is including savings from hiring that person, offsetting the cost of the hire. And there's also a program to assist with placing youth with challenging needs or behaviors, and savings assumed from having those children placed in less restrictive placements, from being adopted, and this is going to be offset by the cost of the program. On a more simple cost shift basis, the governor assumes being able to use federal TANF funds to cover child care costs. This has been done in the past. So there's a total of $2.2 million in additional savings from general revenues for these costs assumed from that. You also received a requested budget amendment. We had noted to you during the child care rate increase hearing that funding was not provided in the DCYF budget to cover the rate increase that dealt with the children being served through this program. So the governor's budget amendment does account for that with an additional $600,000 from TANF funds. There's also a total of about $400,000 in annual education support provided to foster youth. This includes the statutory $200,000 from general revenues and about a matching amount from federal funds. There have been some carry forward surpluses available, and so the revised budget actually has almost $800,000 budgeted, and then the 2022 budget goes back to about the $400,000 level. I mentioned earlier in the presentation about the children's rights settlement. This settlement was the result of a case that was brought back in 2007, and the state agreed to take several steps to settle the case. And this requires that DCYF collect data on certain commitments it made through the settlement, and that would be sent to a data validator. The validator verifies the soundness of that data and sends it to the child advocate, who then figures out whether or not the state has met the commitment it made under this settlement. So the commitment, if the commitment is met for 2 consecutive 6-month periods, the state would no longer be required to report on that commitment. If it's not met, the child advocate can put forth a corrective action plan, and then, successive remedies after that. The next 3 slides just report to you what we're aware of in terms of where the state is on meeting those commitments according to the validation, and there are a number of places where it is not, and I think the folks here tonight may want to talk to you about efforts they're making to meet those commitments or ensure they have the correct data to show they're meeting those commitments. So that's there for your reference. There's also a workload study. The Child Advocate report from 2020 noted there was a failure to meet a number of requirements, and DCYF is required to conduct a workload study in consultation with the monitoring team. Another issue that's come up a number of times has to do with getting accredited, the department going through an accreditation process. The 2019 Assembly provided resources for the department to get that accreditation from the Council on Accreditation, COA. A plan was submitted in October of 2020 that showed what over a 4-year period what would have to happen. It would start with an in-depth self-study, and a more formal and complete analysis would need to take place about how this could come into compliance. None of the costs are noted in that plan, and there's no request or recommendation for additional funding to accomplish this. We've laid out just here for your summary some of the process that the department would have to go through in order to reach this accreditation, and which years that would have to happen. As we move through this, just a reminder that the youth remain under full DCYF care until age 18. And then only those who are developmentally disabled or emotionally disturbed are authorized to remain in congregate care after their 18th birthday, although children may receive transitional services. And there is the voluntary extension of care program that is that transitional program. There's a graphic here kind of to show you what happens after someone turns 18 and who's in the full care and custody of the department, and how the VEC program works through age 21. The enacted budget includes about $800,000, mostly general revenues, to help support the VEC program, 106 participants. There's additional funding provided in the governor's budget. And these are primarily, as I mentioned, those who are not staying on the full caseload. Moving into juvenile corrections, you're familiar with the Rhode Island Training School for Youth, the secure facility for youth placed by an order of the family court. This is a 24-hour facility. And the average population has been reduced over the last several years. You can see that the average population was 40 children in fiscal 2020. It was more than double that in fiscal 2016. Juvenile probation is also the supervision of adolescents outside the training school, and it similarly had a decline in covered population, and is currently averaging about 245 with data through the end of April. There are some of the non-staff expenses related to juvenile corrections include educational services, other support, probation, and parole. From a kind of overhead and administrative perspective, the department's headquarters is on Friendship Street, and much of the staff did transition to remote work during the COVID emergency. And as you may recall from an earlier hearing, there's a plan to have some of this lease get sublet to another entity, and there's budget savings in the governor's budget against this lease, although it's not entirely clear how this will work. There's also funding to ensure that federal funds are maximized against salaries, and that does cost money to have that annual cost allocation plan. There's a proposal to modernize the vehicle fleet. The department has about 104 vehicles. Most of them are state-owned. 20 are currently leased because a number of vehicles were vandalized during the recent summer protests. So the department had to lease some vehicles. The fiscal 22 budget includes funding to continue leases for those 20 vehicles at least through fiscal 2022. And then there's a 2-year plan to start buying some electric vehicles to replace some of the high mileage cars and minivans. In terms of the capital budget, there's the ongoing project for asset protection at the training school, provides about $250,000 a year. The proposal for the training school redesign, and ongoing project to install some generators. I mentioned the fleet project as well. The redesign, there's $1.8 million in each year in 2023 and 2024 to work on a redesign of the training school. This would occur in 3 phases, but that has not been finalized. And then lastly, in terms of major proposals, you already had a hearing on this, I want to say March, on the Child Welfare Information System. So I've just repeated that information here just for your reference. I know you've gone over it and had a hearing on it, but just as a reference point for you, this is to set up a new information system. So that concludes the Department of Children, Youth, and Families budget. And if there's no questions, I'll just keep moving through the Child Advocates budget, which is just a couple of quick summary slides for you.
Go right ahead.
And as most people know, the Child Advocate has responsibility for the child fatality reviews. DCYF is required to notify the Child Advocate's office within 48 hours of a confirmed fatality or near fatality of a child who is subject to a DCYF case. As I mentioned, the settlement with Children's Rights happened, and that involves both DCYF and the Child Advocate. The Child Advocate and the data validator are appointed as a monitoring team. There was a position added in the fiscal 2019 budget to help the Child Advocate discharge those duties. They become the evaluator and final arbiter of the information submitted by DCYF. The Child Advocate's budget is primarily just the small staff and some funding for operations. The budget itself is $1 million, which is about $62,000 less than enacted, and that does require the office to hold 1 position vacant for the whole of 2022. It currently has 8 of its 10 positions filled, so it'd be able to fill 1 more. The revised budget is essentially the same as enacted. In terms of just smaller expenses, very little change from a dollar amount for that for the agency. And that concludes both overviews. Happy to try and answer any questions you may have.
Thank you, Sharon. Any questions on DCYF or the Office of the Child Advocate to Sharon? Vice Chair Slater.
Sharon, I'm not sure if I should direct some of the questions. Thank you for the slides you gave me on the staffing and FTEs, and I had someone reach out to me with a lot of questions as far as like staffing levels. One of the questions that they had was, so if you look at recommended budget for fiscal year 21, there was 640 FTEs at 78.7 million for salaries, and then fiscal year 22 recommended budget is 627.5 FTEs. So the question was, are there 13 less FTEs in the fiscal year 22 recommended budget versus the fiscal year 21, but 0.8 million more in recommended salaries and benefits?
So just the difference, I think the 640 you're talking about is what was requested by the department.
Okay,
So the enacted only had the 617.5, and the governor's budget does 627.5, so a net 10. It takes out a bunch of vacancies in other places, moves them in, and funds almost all of them really from a from a perspective of a large agency, it only requires about less than 2% turnover.
Listen to, and do we still have a number? I remember, I don't know if it was last year's or the year before they start to all run together, but I know at one point there was a lot of vacancies because there was folks asking about adding FTEs, and you know, the committee was essentially saying there's so many positions not filled that they weren't filling. So
right, there are still quite a number of vacancies, and effectively what the governor's budget does, it adds a net 10, but it also, basically there's 29 positions funded that are not filled right now. If you compare vacancies plus the governor's recommendation and all the money attached, I think it's 29. I've got a little slide on that. Let me go back to it. 29 funded but not filled. If you take it and look and see what's in the governor's budget and compare it to today's vacancies and filled positions, right now there's 589 of the 617.
Yeah.
Does that make sense?
Yeah, that makes. And then the other question for the central management budget, the enacted budget for 21 was 12.8 million, and recommended now would be 15.4, which would be about 2.6 million more of funding. You know what that consists of, or the change?
So I'll get you the breakdown. The only thing I would caution you against, and we kind of chase this every year, is sometimes they move people around.
Yeah.
And so you can see that although the staffing appears to be the same, sometimes when you decide to fill more FTEs, even if the staffing doesn't change, you've got to put more money in. But let me double check and see if that's all salaries and benefits or some other component, because sometimes when something's budgeted that is like a one-time, or like the fleet could show up in central management, more of the overhead.
Yeah.
But I will clarify that for you.
All right. Thank you.
You're welcome.
Yeah, and the folks on the administration might be able to
Yeah.
clarify that as well. Any other questions? No other questions. Thank you, as always, for a very comprehensive summary.